I was asked to talk about specialized milk, so I'm going to talk about milk and the feeds in older children. As Dr. Panayat explained to you, I work in King's College Hospital and St. Thomas Hospital, which is a part of Evelina London Children's Hospital. And this is the third time I'm here to do my clinics in Ngomi Medical Center. So I'm a visiting pediatric gastroenterologist. I'm part of your team. I have already contracted in Macquarie's Hospital. So now my objectives of talk is about standard formula milk feeds. The name and the companies are different from UK than here, so it could be slightly different. And the specialized formula milk feeds, which is used in gastroenterology as well as the non-gastroenterology field, and mostly related to the disease-specific type of feeds. I try to cover only the practical aspect of the feeds and the management. Now the choice of the feeds, which formula milk or which type of feeds we need to choose, it depends on the age, because the composition of the milk is very different for the infant from older children, and also depends on the remaining of the gut functions. For example, short gut syndrome is very different from using in other normal children who has a full gut length. And also whether other dietary restrictions are in place and a specific requirement related to the certain deficiencies. And route of administration is also important, where the feed is going to be. If it is in the stomach or the jejunum, then the type of feeds selection should vary. And also one should take into account, because we are going to prescribe these feeds for a long period, so whether it is available, and the cost of the feeds also plays a role before you decide which type of feeds you want to choose. Generally, you choose for a specialist milk in malnutrition, which still we see in the hospital or related to disease, food allergies and growth failure, short gut syndrome, and inflammatory bowel disease. There are special feeds also available for liver-related conditions, chronic liver disease, and chronic renal failure, and number of metabolic conditions, and also neurology like a ketogenic diet. The enteral feeds or specialist feeds are available as a ready-made preparation, depends on the concentration of the carbohydrate or the content of the carbohydrate and type of the protein, and also amount of the fat, like long-chain fatty acid or the medium-chain fatty acids. And there are also modular feeds, which are specialized feeds used in special situations where you can make the feeds in the ward or in the dietitian kitchens. We add appropriate proportion of the carbohydrate, protein, fat, and also vitamins, minerals, and trace elements. Now, all the formula milks nearly follow kind of same formula to produce milk. It's usually you have a carbohydrate which comes from either maltodextrin or glucose syrup. And protein is generally comes from either whey or casein protein. These are the two major proteins in the milk. And also you can have a digested proteins, and different formulas available on that as well. Most of the available formulas are gluten-free. And the fat usually comes from either vegetable or soya, corn, palm, nuts, and seeds. And also you can have a formula which comes from animal as well as the fish. Then you add vitamin, mineral, and trace elements into it. We don't generally like to choose in children feeds which has a more than 6 grams per 100 ml of protein. High protein diet means you're putting the kidney at risk and also the liver. And the 2 gram or 100 ml fiber should be avoided. Most companies, they market as have a high MCT. If you have at least more than 30% MCT, it's beneficial for GA conditions. And they label as a lactose-free if there is a less than 1 gram of lactose in 100 ml of milk. So it's not completely lactose-free, most of the formulas what you get. With regards to the protein, and the indigeneity of the protein varies, depends on whether it's the intact protein or whether it is amino acid. So the amino acid has a low indigenicity, and in between you have a small peptide or large peptide or incomplete protein where there's indigeneity is high. So the hydrolysis of protein, it's somewhere in between, means you still have some indigenicity exists that can cause protein allergy. If it is amino acids, it's completely allergy free. So you can see the complex protein here, which is digested and down to the amino acid level there. More and more, we just heard from Professor Hazard how beneficial is this breast milk. And more companies are making, or at least they are advertising as they are making milk which is closer to the breast milk. So they are trying to introduce more additives into the breast milk. You can see arachidonic acid or DHA, iron fortified or probiotics, prebiotics, and also nucleotides, prebiotics. They claim these are helpful either for a brain development or eye development, same as the advantage of the breastfeeding, and also to improve the gut function. I thought to talk about as a practical case scenario, to start with a case scenario and then take you along the available different milk products. Amy, who is a 9-month-old girl, presented with fever, vomiting, and diarrhea for 5 days. And she was seen by a GP. I guess here you will be seen by a pediatrician straight away. But the GP reassured her as it's possibly viral infection, which we all do. And 2 weeks later, the patient presented to a pediatrician with ongoing diarrhea and a perianal rash. I'm sure it's all common scenario you will see in the practice every day. And the stool was frothy with no blood or mucus. Now you all know the lactase-specific activities from the duodenal enzyme. It's usually high at birth, and then it gradually falls. It's the same in the mammals as well. And after the age of around 5 to 7, the levels gradually decreases. Most of the adults, especially non-Europeans, actually lactose deficient. Someone doesn't need a full lactase enzyme to digest the lactose in the sugar. But certainly in the first few years, you have a good lactase enzyme activity. Now, congenital lactase deficiency is very rare. The primary lactase deficiency, the one I talked to you with that previous slide. So most adults are actually lactose intolerant. And in children, especially small babies, if they are breastfeeding, and the lactose deficiency is very, very unusual. But in children who is already on formula fed, and their exposure to the lactose is not that high, and they develop a secondary lactose deficiency, especially when there is a damage to the villi due to the gastroenteritis. There are a number of formulas milk available. Generally, between 0 to 12 months, we use milk called SMA lacto-free, which is available, and Enfamil lacto-free, produced by a different company, and also a galactomin 17, which is also completely lacto-free, and which is used in galactosemia. Soya milk is not recommended in small children, definitely not recommended under the age of 6 months, and it's not widely used under the age of 1. Over the age of 1, you could use a soya milk in a situation where we have a lactose intolerance is suspected, or there is also full-fat lacto-free milk is available from the supermarket, which you can buy. You can also add a lactase enzyme, which is ready-madely available, add into the milk. As I said, if a baby is breastfeeding, there is no need to change to any of these formula milk. How about a different formula milk if you are suspecting for a lactose intolerance? It's generally not recommended any other mammalian milks. The possible reasons are high renal solid load and inadequate vitamins and mineral supplements, and also goat and sheep milk, they share some cross antigenicity. Soya milk, the concerns with the soya milk is not recommended under the age of 6 months is due to the estrogen contents or the phytoestrogen which mimics estrogen, and that has a negative impact on the development. Now, the isoflavones, which are these chemical related to the estrogens, which is high risk in the first 6 months of the life. So that is another reason why it's definitely not recommended in the early age. There are a number of studies done about it, and they concluded at least 4 milligram per kilogram of isoflavones are going to be there if you fed with the soya milk in the first 4 to 6 months in the infantile life, which is actually not healthy. This is why they avoid it. And also, cows, up to 1/3 of children who is intolerant to cow's milk can also be intolerant to soya. That's another reason why if you're suspecting a lactose intolerance or cow's milk intolerance, then soya milk is not the right choice. Professor Gideon Lack from St. Mary's Hospital also did some study in 2013, and British Dietetic Association, they suggested there's a possibility if someone is allergic to soya, they could be also allergic to the peanut. So there is another, there is also increases the cross reactivity, because soya and peanut, they are all legumes and are the same antigens. Chief Medical Officer statement from UK 2004, they finally concluded soya formula milk should not be the first choice for the management of infants with proven cow's milk sensitivity. So it's not recommended. And it should be used only in exceptional circumstances where infant with the cow's milk allergy or intolerance who refuse extensively hydrolyzed or elemental formula, or strictly vegan mothers, or galactosemia. In other scenarios, soya milk is not being used. Now, coming back to our case scenario, Amy, who is better now on lactose-free formula, but her weight gain is still slow. After 8 weeks, the lactose formula was reintroduced, but her symptoms returned again. Now, as you know, acute gastroenteritis causes damage to the mucosa of the small intestine, which causes the secondary lactose deficiency, leading to secondary lactose intolerance. This is usually a temporary problem. One should expect these symptoms improve within 6 to 8 week periods. But what happens in the damaged mucosa? There's an absorption of cow's milk antigen, leading to sensitivity to the cow's milk protein, so they develop secondary cow's milk protein enteropathy. So that's what happened here with Emmy. And if you do an endoscopy on these children, often you see, either lack of villi here you can see, there is no villi you can see, or you can see a normal villi here. Now these changes are patchy, so the endoscopy could come back as normal if you take the biopsy from the normal area, which is a patchy edges here, or if you take the biopsy from here, it will come back as an enteropathy. So generally, we don't put children through these tests. If we are suspecting cow's milk protein enteropathy sensitivity, then you change the formula milk. So which formula you choose? The cow's milk protein allergy is based due to the two major proteins in the cow's milk, which is whey, which is 20% of the protein, or casein, which is from the 80% of the total cow's milk protein. Now whey, as you all know, generally it causes rapid gastric emptying, which is a better one. But it has a alpha-lactamine and beta-lactoglobulin. These are the two major antigen which causes actually cow's milk protein intolerance or allergy. This is heat responsive. The casein, which causes slow emptying, which is generally not recommended in, and it's mainly used as a hungrier babies, or it's a heat-resistant antigen. There are a number of other cow's milk protein allergens, but these are the two major allergens which causes the antigenicity. So in the market, you have a different type of formulas available. Standard formulas, which is whey-based or casein-based. If it's a whey-based formulas, Covengate Premium, SMA Gold, or Farley's First, Aptamil. Casein-based, Covengate Plus, or SMA White, Farley Second, or Aptamil Extra. I'm not sure whether you have the same brand here, but there are companies with the same companies who makes the formula, they're making it here as well. So this is possibly better because in terms of the gastric emptying. And as I mentioned earlier, casein-based formulas are used as a slow gastric emptying for hungrier babies. So coming back to Emmy, so if someone is as a management as a breastfeeding, then the first management should be maternal exclusion for at least 6 weeks. Cow's milk protein allergen passes through the breast milk and it causes antigenicity for the baby. So if you exclude it for at least 6 weeks, and that have a significant improvement, which you will see from the 2 weeks onwards. What about if they are more than 6 months and if they are not breastfeeding, then the first choice would be a hydrolyzed formula. As I said, Ysaia or Infesaia could be used, but it's not, again, ideally recommended. If they are more than 12 months, generally we use soya milk if you are suspecting cow's milk protein intolerance or allergy. Now, in a formula-fed babies, you use the hydrolyzed formula as a first choice, and if they fail, then you go for the amino acid formula. In older children, more than 2 years of age, you can get a calcium-rich soya milk, which you can buy over the counter from the supermarket, or also oat milk. Generally, rice milk is not recommended under the age of 5. it's not available or even in supermarket. If the rice milk is, we tell the parents not to use. It's mainly there are some concerns about the lead content in it. So coming back to the hydrolyzed formula, so again there are so many formulas available. Which one you are going to choose? How? I mean, most of them are it's same, apart from whether it's a whey-based or casein-based, and the cost. The taste of the formula is different, depends on how extensively this formula protein is digested, depends on whether it's amino acid formula, it doesn't taste very nice, and the peptide formula or the partially hydrolyzed formula tastes slightly better. For an infant, you can have a, either whey-based formula Pepti or Pepti Junior, or in casein-based Nutramigen 1 or Progestamil. Among the older children, you can have again Pepti or Nutramigen 2, Peptamin Junior, Nutrini Pepti Sorb or Peptide 1 Plus. So what's the major difference? Why do we have a different formula with different companies making a different protein concentrations? And it depends on the how much amount of undigested proteins there, and that causes antigenicity. This is the major advantage of choosing the right formula. Pepti Junior, for example, if you take the protein, it's only 63% of the proteins are less than 1000 Dalton. It's how much they digested into a peptide. Again, on the other hand, Nutramigen, you have a 95% are digested, so it's an extensively hydrolyzed formula there. In Progestamil, again, it's a hydrolyzed formula which has a MCT in it. If you're suspecting a child who has also malabsorption, then Progestamil may be better because the MCT absorbs easily. As I said to you, in how you decide depends on the number one, taste. You start with the hydrolyzed formula, and if the baby likes it, taste, and the symptom improving, then you continue that. And depends on how much fat you want in that formula, or if the child has associated other malabsorption, then you want to have a MCT. And then cost. If the child is going to be on this special formula milk at least for a year, so I mean, it's all private here. And generally, if it is a government is supplying it, then you need to have a worry about how much it's going to cost. Also, if parents are vegetarians, then there are certain hydrolyzed formulas are coming from, like the enzymes are made from pork, so they may want to choose a formula which doesn't have a pork. So these are the main factors in deciding which type of hydrolyzed formula which we need to choose. Now, if you coming back to the amino acid formulas, you all know amino acids are the building blocks of the protein. There are about 20 amino acids are there. Depends on which amino group and carboxyl group. These are get pre-digested and then formed as a amino acid formula milk. The tastes are, I don't know how many of you had a chance to taste the formula milk. Amino acid formula milk is actually not the best taste. Most parents, when you see them in the clinic, they tell you, oh, it smells bad, and it makes the poo smells bad, and also it doesn't taste nice. But surprisingly, number of babies you see, they may drink well. On the other hand, there are small percentage of children, they don't like it at all. So you have stuck with choice, but fortunately, we have different companies with making a formula, and the taste could also different. Neocate LCP, Nutramigen AA, this is a common type of formulas which we used in this infant. Neocate spoon, which is used in more than 6 months of old babies, whereas after you started to wean the babies. In older children, you have Neocate Active, Neocate Advanced, which is a complete formula, and Evo28 Extra or Esmogen. This is also used as a amino acid formula for certain specific scenario. So what happens in the long term with the cow's milk protein allergy? At least about 50% of the time, 50% of the patients grow out of the cow's milk protein allergy by the age of around 1, and 75% by 2, and 90% by 3. About less than 1%, their symptoms persist. They may still need a special formula or a hydrolyzed or amino acid formula on a long term. Okay, coming back to the scenario 3 there, Emmy, now diarrhea is better, her weight gain is better, and the milk is reintroduced after 6 months. And the 12 weeks later, mother represented with irritability, backarchic, and refusing solids. So the diagnosis here is gastroesophageal reflux. Often children with the cow's milk protein allergy also has a gastroesophageal reflux. Generally, in my clinic, we don't prescribe any of those. These are the milk thickeners, Carabel, Gaviscon, Infant. Also, you have a formula fed infants, you have pre-made formulas available, SMA, stay down, and Enfamil. Often it may mask the symptoms, doesn't actually cure the reflux itself. So this baby had that, but the weight continued to drop and dropped to 0.4 centile, and the low weight for height and crossing the centile. So what's next? So you have diagnosis of faltering growth there. In an infant, you expect them at least to have 130 to 150 kilocalories per day, per kilogram, with the protein of about 3.4 to 5 gram per kilogram. In an older children, you have a less protein, and again 120% of energy intake is adequate. Professor Hada talked about the protein content and the fat content before. I just put this here for a comparison with the available formula milks in my next slides. You can see the TAM formulas has a protein up to 1.4 to 1.5, and the pre-TAM formula has a high protein intake. It's the same thing with the fat content is different between the TAM and the pre-TAM babies, and the calories only TAM babies have a 67 to 68, and in a pre-TAM formula you have a high calories 80 to 82. If you compare the hydrolyzed formula to the amino acid formula, again, the protein content from the amino acid formula and hydrolyzed more or less the same, but the calorie intake between the hydrolyzed formula and the amino acid formula is slightly different. Amino acid formula is a bit better. So what do you do in a child who is having a cow's milk protein intolerance and failing to grow? Number one, you increase the volume, or you can use the ready-made feeds, or you can concentrate the feeds, or you can include more glucose or fat add into the formula milk. There are again ready-made formula milks available, such as a high-energy milk like SMA High Energy, which has 91 kilocalories in 100 ml, or you can get even higher calories like Infetrini, which has a 1 kilocalorie per ml. Other similar high energy, it's the same. In an older children, there is no ready-made formulas milk for oral intake, but you can have a high-calorie food or concentrate on the behavioral problems. So how do you concentrate it? One should aim to concentrate the feeds only maximum up to 500 osmolality per kilogram, not higher than that. So generally, the standard feeds concentration comes as a 13%. So that means 13 gram in 100 ml. And you gradually increase that to 15%, 17%, or 17 gram in 100 ml. But generally, this is done with the help of dietitian to keep the protein and the calorie ratio between 7.5 to 12%. So how do you add the extra calories into the milk already the baby is taking? As you all know, most calories comes from fat, and the carbohydrate is only 4 kilogram per gram. So if you want to increase the calorie intake, fat could be the number one, but it's not ideal. So you start with the carbohydrate. You increase 1% every 24 hours. If you increase too quickly, then you have a more osmotic effect, and the osmotic effect leading to more diarrhea. And then you can gradually increase this concentration, maximum up to 30% in older children, and in small children up to 15%. Generally, this is tried in the hospital with the help of dietitian. Step 2, you can add more fat into it. LCT, long chain, is preferred in this scenario due to less osmotic effect, providing there is no malabsorption. And again, you can increase the fat up to the 7%. Rarely someone needs to increase the protein content of the milk. So to add the extra calories in the older children, there are again ready-made high-calorie foods are available. You can have a juice, like a 40 juice or ensure juice, or you can have a special type of yogurt, high-protein feeds like a frizzy bean, 2 calories, which is available as a formula like a chocolate bar. And also you can have a fiber and semi-solid desserts also available. If you want to add extra calories into the milk, you can use Maxijule, which is purely carbohydrate, or polycal. If you want a fat, we can add halogen into it. If you want fat and carbohydrate, Diocol could be added into the formula milk. Protein, as you said, proteins rarely someone needs to be added unless in special metabolic conditions. And you can also add OptiFiber in a special situation like where you, in a short bowel syndrome where you want extra fiber, you could add OptiFiber into the formula milk. If someone is using a modular feeds, you can add extra vitamins called Ceravit into the feeds to add extra into the same formula milk. So coming to the short bowel syndrome, again there's using a normal formula, it is going to be slightly different in a child who has only short gut. It's mainly because their intestinal permeability is different, and the luminal surface area is less, and they have a smaller gut length, and also the quality of the mucosa may not be the same as the normal children. And presence of ileocecal valve also plays a role in the which formula you are supposed to choose. The recommendation is generally in a breastfeeding, short gut children, if they have a reasonable amount of the gut, to continue the breast milk, because the breast milk has a glutamine and a appropriate LCT and a growth hormone, and there are a lot of evidence that continuing breastfeeding or expressed breast milk is best for a short gut syndrome kids. Even you can use this breast milk via the tube. Undigested or a full protein food also be useful if you have a jejunum in place, because the jejunum is the place where the protein is going to be digested, broken down into the amino acids. If there is no, if the jejunum is mainly the ileum, then someone may want to choose a different type of formula milk. But if you have enough length of jejunum, then there is a little benefit in using the amino acid formula in this scenario. Full protein, it actually helps for the better adaptation of the bowel. If the broken down amino acids, it's supposed to absorb directly, but the adaptation is much less. So if your patient has a less luminal surface for digestion, and if there's associated inflammation, for example, a cow's milk protein intolerance could be associated. In this scenario, we go for amino acid formula as a first choice. Otherwise, generally, you go for the full protein formula. Again, someone can also
2.5 minutes left.
One can also select that depends on the type of formula milk, fat content, like whether it's a LCT or a MCT, progestamil or peptijunior. Progestamil and peptijunior has a more MCT, which is actually an advantageous in a certain scenario like a lymphangiectasia. If all this fails, then we go for modular feeds. Modular feeds means, as we explained to you earlier on, it's you make the feeds yourself in the dietitian, with the help of the dietitian, with the appropriate amount of carbohydrates, protein, and the fat, and vitamins. Essentially, one is aiming for a neocate with the MCT as a basic option. Neocate, it has a high osmolality, so it's not ideal in a scenario when a child has a short bowel syndrome, unless if there is an associated inflammation or intolerance. So in this scenario, we use a modular feeds. Which I talked to you already. So I don't know whether you can make it up. You can see this is a child with us who had a bowel transplantation. You can see some white patches in the bowel wall. This is a diagnostic of intestinal lymphangiectasia. In this scenario, we use MCT enhanced feeds, specifically Monogen, Caprilon, or Progestamil, Peptijunior, which has a high MCT. If one need a long chain fatty acid, then you can use a Nitromigen or Pepti or Neocate. Galactomin 19. Recently, we had a baby who was admitted in the neonatal intensive care unit with a severe dehydration following severe diarrhia. Not responded to the amino acid based formula or any change of the other formula milk. Actually, the child had glucose and galactose malabsorption. In this scenario, only you need to use a fructose based formula. So galactose 19, it's a fructose based formula, so you don't need actually glucose. The last one is a congenital sucrase enzyme deficiency. This is again usually children presents with the diarrhea after you introduce the solid or into the weaning product. Due to the starch and sucrose content, and they start to have a more diarrhea. The treatment is usually avoiding starch and sucrose, but there are also ready-made products of sucrate which is available. You can actually mix it into the cow's formula milk. That is actually a curative treatment for this. Finally, we have an inflammatory bowel disease for an older children, where you can see this is an endoscopy picture with the deep ulcers, and you have a stricture and the barium study. We say exclusive enteral nutrition. Generally, this has been used for up to 6 weeks of exclusive enteral nutrition. There are different formula milks available. Again, Mardelin, Evo28 Extra, Alicam. Mardelin is a polymeric feeds, and Evo28 Extra is completely pre-digested. It's an amino acid-based formula. This is used as a first step in a Crohn's disease patients if they have a mild or moderate disease. The mechanism is generally, it has a anti-inflammatory effect, and also it changes the bacterial flora in the gut, and by that way, indirectly, it changes the balance between the anti-inflammatory and the pro-inflammatory cytokines, leading to a healing of the ulcers. Other available formula milks like Generite, General Plus, and Heparin Junior. This is widely used in children with a chronic liver disease prior to the transplantation to improve their nutrition. In a chronic renal failure, again, number of formula milks like Kindergen, Renamil, Renapro, Renastat. Epilepsy children who have a ketocol. In a pancreatic patient failure or pancreatic carcinoma, where we have a Forticar. In a metabolic children with methylmalonic acidemia or phenylketonuria, again, there are special milk feeds available. The list is exhaustive. Again, different company make a different names. It's confusing, but in summary, in most feeds we use in general either full protein, which is a standard formula, or broken down protein hydrolyzed formula, which is the first choice for any cow's milk protein allergy, and then amino acid based formula, which is used in a scenario where the hydrolyzed formula fails. Thank you.